In this podcast series, we'll dive into the world of SDOH data, exploring what it is, why it matters, how it impacts the healthcare economics, and the obstacles and opportunities associated with it. We'll also discuss how healthcare organizations can leverage health IT and other tools to unlock the power of SDOH data and discover utilization patterns to better understand populations. If you're looking to navigate the value-based care world more smoothly and unlock the power of SDOH data, you've come to the right place. Let's get started. Episode 3: How to monitor your SDOH initiatives. How to up the game.
Welcome again to our the last and the third episode on how to monitor our SDOH initiatives and how to up the game. We are in the VBC environment now, and we are transitioning from fee-for-service to models such as ACO REACH, which I think is one of the first one to incorporate the health equity benchmark, incorporating the ADI data. Shannon, what are your thoughts on that?
Well, one of the requirements is that you identify a patient population and that you have a robust plan for how you're going to ensure that they are receiving not equal, right? There's a difference here between equality and equity, but how are you providing equitable care? And so it's really understanding how certain populations may be different, may take up their health care differently. And so what are you doing, right? And it's on us. What are we doing to ensure that those patients are getting the care that they need? And so, just to talk a little bit more about equal and equitable, equal is really everybody gets the same. Well, not everybody needs the same because they're all coming from a different place. And so what's equitable? What do people need, right, to get healthy? And for different groups, that's different things. And unless you have an understanding of who they are and where they're from, that can make that very difficult.
Absolutely. What was exciting for me was that the ACO REACH model actually incorporates some of this data, like the area deprivation index, the ADI index, and rewards providers for taking care of patients who are in the top 10th decile. So I thought that was very interesting that CMS is experimenting with that they're not only saying that you need to have a plan to be providing equitable care, but they're actually rewarding providers based on some of the data. How do you think technology can help with collection analysis of SDOH data and help us get to a place where we can really leverage this data in improving care and improving VBC type of models?
So, excellent question. I really love ACO REACH because I think that it's a step in the right direction, right? It empowers physicians to be able to provide care in a way that only they would know, right, what their patients need. And, to your point about addressing health equity and that social disparity index, it's one thing to collect the data. It's another, though, to be able to use it to drive action. And I think that's what's key. And so being able to collect that data at the point of care, being able to use that to identify those patients, like I said, really know what their needs are, is so important in devising those plans. One of the other things too, though, around value-based care and plans like REACH that I think that physicians need to understand and others in the industry is that it's not just about risk and assessing the acuity of a patient and having a risk score. It's not just about quality measures and investing in health prevention and then management of diseases once the patient is on that trajectory, but it's also equally important is total cost of care. And working with several IPA groups today, that's one of the things that I'm finding that they're struggling with. And that's where I think SDOH and the collection of that data can be really helpful. if you look at, and speaking about ACO REACH in particular, but this would apply too for our Medicare Advantage organizations that are now, trying to figure out what V28 means for them, is, how are they managing total cost of care? And so what I found with a lot of the groups is that their expenses are difficult to manage. One of the best ways that you can do that is understanding your population. And I know in an earlier episode, we talked about, inappropriate use, say, of the ER. How do you understand who the patients are that, say, need housing, are food insecure, need supports when they're released from the hospital? All this information, right, that SDOH and SDOH data can provide to better, to help better the care for the patient, because it's not a medical thing, right? When they're showing up to the ER, it's a social thing, it's a psychological thing. And so we have other ways, better ways to treat that. When I see patients that show up in the ER looking for, a place to stay, a warm bed, food, it really is only treating the symptoms, and only treating those symptoms, for a very short time frame. It's really not fixing the larger issue. But if we have SDOH data, we're able to connect people to the right organizations. We can save on the cost of care, because the care, right, is different. And like I said, it's really in the social and psychological realms that it needs to occur. And if it's done well and done right, it's far less expensive. And when we look at just overall, participation in these programs, I worry for our physicians, especially those that are participating in REACH or our MAO partners, that if they're not paying attention to all those components, it's not enough, right? It's like a three-legged stool. If you take one leg away, it'll collapse. And so it's not enough to focus on risk. It's not enough to focus on quality. You really need to be attending to total cost of care. And I really think that SDOH is the way forward with that.
That's a great point, and I agree with you. I think we really need to rethink how we provide care at the health system level, at national policy level, because now everything is coming together. Health is bigger than just seeing a doctor or having a visit to the ER. We really have to take care of that patient. We really have to answer these serious questions now for us to move forward as a society. So I do agree with you on that. What are the next steps we as an industry can take so that we can accomplish providing the health equity goals, we accomplish the health equity goals, and how can the payers and the providers work together? Sometimes, more often than not, their interests are opposed to each other rather than aligned with each other.
I think that there are ways to organize your operational teams to focus on this work, and really sitting down and being strategic. There's lots of different methods that you can apply to developing a good plan if you're a physician group where you're wanting to address a particular population, say, as part of that health equity plan that needs to be devised related to ACO REACH, or if you're a health plan, how are you getting to those populations? And so there's definitely a science and a method to implementing those programs. But I think the bigger challenge is the sharing of data and the standardization of that data. We have data all over, and how do we bring that together to tell that cohesive story, right, about our patients? We need to get to this point of interoperability. If I were a physician group participating in REACH, one of the first things that I would do is I would invest in a platform that would help me bring all that information together. Same thing with health plans and others. What platforms are out there that you can bring data together? And the thing is you need to listen, right? If something seems too good to be true, you need to vet. You need to definitely vet the vendors that you're speaking with. I've looked at a lot of them, and it looks good on the face, but when you really dig into the back end, they do not have the infrastructure to do the things that we really need, right? That are necessary to move the needle, if you will. I definitely think Persivia is the best tool on the market as far as bringing together the data, being able to tell that patient's story, the fact that you can have at the point of care, right? The patient's in front of you. When they leave that office, you lose that opportunity to really have an impact. But when you're face to face in the office and you have the ability to see what their risk score is, what conditions need to be addressed, what quality measures are needed, right? What preventative measures need to be addressed, as well as their social determinants of health, right? What they might be at risk for. And there's lots of working and algorithms and measurement behind the scenes that's going into that makes it easy for the physician at the point of care. And one of the things that I appreciate the most about Persivia too is that it was designed, right, by physicians. And so who better to inform that work and what's needed and the tools that are needed at the point of care than someone who really understands healthcare and what it's like to be a physician and working with patients, and what are the tools that are needed in order to get the data that's necessary to make a difference.
Thank you, Dr. Decker. I am one of the co-founders of Persivia, and the idea came to me when I was serving in one of the medical centers, and I noticed in the computer or EMR, then a patient's lab values for a medication are going sky high. And I didn't wait. I ran up to the floor and said, guys, what's going on here? And there was some slip and they forgot to turn off the drip. So at that point, I thought, we need to have a better way to prevent these medical errors so that some system, some evidence-based algorithms, some AI is watching us and helping our providers and easing their burden so they can better focus their energies and thoughts to their patients and not on these type of things which we can automate.
Well, and Dr. Khan, truly, that's one of the reasons why I love the product so much. It's just the thought, your level of experience, minding the gap. That's something that I think has always been a challenge. We either talk about operations or we talk about the clinical work. And so someone who can really bridge that gap between practice, right? And then what's right for the patients. And then also to just the flexibility and the forethought that you have in making sure that there's a lot of systems out there that do just risk or just do quality or just SDOH, but bringing the whole picture together is so important. And I know that you were talking earlier about, treating the whole human. Really believe that it's that biopsychosocial model that is so important that we need to use to continue to push ourselves forward, to do the best that we can, not only in healthcare and patient outcomes, but also too, so that our physicians can be successful with things like ACO REACH or their value-based care contracts that they have with their, our payer partners.
Great, thank you. Now that we are at the end of our third episode, I would like you to share some of the real life lessons, some positive, happy news across the health system where you've seen that we are actually leveraging the SDOH data, we are collecting it well, and we're using it well, we're impacting our patients in a positive way.
Just from experience, being able to, like I said, identify when we have patients that maybe need support beyond what we're able to provide in the office. I've met patients at health fairs. I can think of one in particular that came to me and needed help. She was there for, we were doing preventative screenings that day. But when she came, she needed help with a $20 copay. And for most
Oh,
of us, right, we wouldn't think that
yeah.
that's an issue, but it truly can be for some populations. In that discussion, understanding that a lot of the things that we think are important don't always land in the way or resonate in the way in which our people, right, or our patients need. And so, in the instance of this particular patient and member of our physician group, uh, like I said, it was the $20 copay, but things like gym benefits she was using to take a shower because she happened to be homeless,
Oh,
right? And living in her car. And she was relatively healthy. But again, a lot of the plans and a lot of the benefits that we put out there that we think are going to be important don't end up being used in the way in which we intended. This particular patient too told me about her prescription card. She happened to be a what we call a Medi-Medi. So she was eligible for both Medicare Advantage as well as Medicaid. And she couldn't use her prescription card because she wasn't sick. She wanted to be able to buy vitamins and to be healthy. And so I think, I had that long conversation and spent a lot of time with her. But I think that there are tools in addition to that conversation, because I think that that's important. But perhaps we could have gotten there a lot sooner, or perhaps we could have prevented some of the instances or the situation that she was in. And had we been able to do that, we would have known, right? And we would have been smarter around benefit design and the services and the supports that we're providing that patient. And again, here we had the best of intentions, but they just didn't resonate or land in the way in which we intended, which I think is significant because we could devise better benefits rather than asking our patients or our members to fit our model. How do we fit for them? And again, I think that having that SDOH data at the point of care is so important. Knowing, what are you releasing? We know that readmission rates are so important, especially around ACO reach, right? We want to make sure that patients that were in the hospital don't get readmitted. And we also want to make sure that those patients that are likely, right, because of their chronic conditions to get admitted, we're putting in supports ahead of time to prevent them, right, from having to go to the hospital and then having an inpatient stay for something that could have been managed outside of that environment. And so I think that had we known, right, had we known that the patient had challenges with understanding what medication to take, or that we were releasing them from the hospital into an environment that wasn't necessarily safe, right, didn't have grab bars, or, things like that, I think are all stories that I'm aware of, and opportunities to improve. I just heard a story the other day, and that's why I mentioned grab bars. Would you rather risk a hip fracture and someone falling? Think about the cost there, the cost of going into the ER, and then the exacerbation that could come from, an inpatient stay from someone falling, as opposed to the cost of a grab bar. And so it just, you look at that and it just makes sense, right, of what we need to do. And so if we just inserted ourselves earlier in the process, had actionable data that we could get into the home, provide those supports, provide those services, we could avoid um, a lot of exorbitant cost in the end. And I think that there's an opportunity here. It's a paradigm shift, right? It's moving from being reactive to proactive. And that's going to make the difference in moving healthcare forward for better outcomes for our patients, as well as, connecting that fractured care, supporting physicians in the work that they do, and really having a sustainable healthcare model.
great. Thank you so much. Thank you for joining us for these episodes. I really appreciate your insights. Take care. Bye-bye.